Good evening, everyone, and good afternoon to you guys on the West Coast. Thanks for joining me tonight. Viva Learning has been kind enough to invite me to give you my spiel on predictable dynamic navigated implant surgery. So hopefully I can give you guys a few pearls over the next 45 to 50 minutes. My name is Dr. Robert Pauley. I've been practicing dentistry in the Atlanta area for, geez, a little bit over 33 years. Been involved in the implant arena for the last 15 and really have enjoyed getting into the implant arena as far as the actual surgery. And then tonight a lot we'll talk about with the surgery goes, a lot of planning in our digital platforms. So let's just jump right in. You know, when we're talking about digital dentistry and in implant arena, you've got all kinds of partners or all kinds of different circles that are going to make our whole experience worthwhile. First off, we've obviously got to start with the patient, but then you're going to need your CBCT, which I think pretty much now is a standard of care. If you're going to jump in and start either singles or the full arch reconstruction cases, along with the CBCT, you'll need some planning software. Tonight you'll see both some planning from my software with my CBCT as well as the DTX implant planning software. With your CT, you obviously will need your intraoral scanner. And you can kind of match up those DICOMs and STL files that you're able to present to the lab to help you make your provisionals, to help you treatment plan some digital workups and such. And then ultimately, in this case, I've been using XGuide as my dynamic navigation, treatment planning, and surgical technology for a little over 5 years now. When I think about and I look back at my journey in the implant arena and guidance for that matter, you know, I'm almost like the World War II pilot here. You see, he's got a rudimentary cockpit. He still has dials, altimeters, speed control, and at the time it was probably the best that we had to offer him. And I equate that to my experience when I started placing implants. At that time, we could use a BB technique. And with that, I don't know if you guys, everyone's old enough to know this technique, but you knew the size of the BB when you placed it in your PA. And you had software in your imaging that could let you tell if you'd elongated or shortened it, so you would know the exact diameter of your BB spear, and you can use that to help you treatment plan your length and width in your implant site. And in this case, it looks really nice. Some of the first ones I've done in the posterior, we blended together, and they're still functioning today. But if you looked at the CBCT, it's like wipe the sweat off your brow because you have gone any deeper and not been in the lingual concavity. So what was the advances past the BB? And I look, and this was my good friend, Dr. Rick Kimbrell, in one of his earlier planes. And you see now his cockpit is more advanced. He has more instrumentation to help him pre-plan his flight and to actually navigate and fly the plane. And I thought of this was along the lines of when I first started using static guides. In this case, it was a static guide, just mainly for the pilot holes. But in this case, instead of me worrying about my spacing for 3 implants, instead of a 3-unit bridge to give the patient a little more cleansability and flossing, with this guide, I was able to utilize that to get the actual preliminary drills in the right place, right time, and then from there freehand these into place. And this was another great step. But now going on past that, I think, okay, what else is available? Well, you think the Delta pilot that flew you on your last trip. He has all this new instrumentation. He has a virtual cockpit. It's going to help him with communications, as well as like we would communicate with the lab, and it's going to help him with his navigation. So he knows his flight time and route pretty much before he even begins the trip. And that's kind of like what we're doing in our implant arena. We're, your prosthetically driven implant placement, where you're placing your implants according to where they need to be placed with the final crown or the final full arch restoration. That really negates and stops a lot of trouble versus just going in and placing the implants and then trying to restore those later. It's a wonderful book here. Don't know if, some of you, I'm sure, have heard of Dr. Scott Gans. I love this quote. There's danger when we're bound by 2 dimensions in a 3-dimensional world. And then now people are even talking of 4 dimensions. But here's a case that we have where the implants are planned, bone reduction's been planned, and our prosthesis is planned. A nice case workup with Lars Hansen. But this is a wonderful text for anyone who's interested. Dr. Rinaldi and Drs. Rinaldi and Gans are a couple of my mentors. And with Dr. Motolo, this is a great book in that the first half of the book will be talking about actual literature as far as dental implants, the grafting, the reconstruction. So we'll talk about sinus grafts, bridge splits, those sort of things as a text. And then in the second half of the book, they'll have actual surgeries that they've discussed and planned and carry out. So you get to kind of rehearse a surgery that you may be doing the next day or the next week. You can read that particular type of surgery and kind of plan that in your head, before you get going with the actual surgery day. So it makes again, it helps you on the front end. You're getting your predictability really in tune. That's the great thing, I think, about digital dentistry. Our learning objectives today are understand the different approaches to implant surgery and where X-guide or navigated surgery will fit in to your practice. Review some clinical evidence, because you really need to practice on evidence-based dentistry. And I'll try to show that in a few of my cases tonight. We'll talk about patient and clinical benefits of navigated surgery for simple and a complex case. And finally, we'll learn how, we'll talk about how X-guide practices can leverage navigated surgery solutions as a marketing tool. So we'll talk a little bit about how staff and patients see or perceive your office when you are able to treatment plan in front of them and show them your sequencing when you're going to plan and perform dynamic navigation. So what kind of cases can we navigate? Well, we'll obviously implants, placement, sinus elevation, minimally invasive cases. Here's a case where we're doing a sinus elevation where we only have about 4.5 millimeters of bone till we get to the sinus floor. So we're able to use our navigation to hit the bullseye to get our implant exactly where we want it. And in these kind of cases, I will take it up to the 2nd or 3rd osteotomy drill size before we do the final push up and lift through the crestal approach. We'll use this on highly aesthetic cases. It's very helpful in immediate extractions, bone grafts, when you have convergent roots, a narrow ridge, when you're worried about the inferior alveolar nerve. It'll help you either reposition that, or you can make sure you stay buccal or lingual to that. I use it in terminal dentition or totally edentulous cases. We'll discuss some full arch, and occasionally we'll do dual full arch cases. Here's a case of an oral surgeon that is doing a little off-label utilization, Dr. Michael Hartman, but his research had shown him that when he's going after these deeply impacted third molars, a lot of times it will not, the jaw will not have a pathological fracture when they're taking the tooth out. But when the tooth's taken out, the cyst is removed, and the patient starts eating again 2 or 3 weeks later, and he thinks everything's fine, they'll then notice a fracture. So in this case, Dr. Hartman has treatment planned his brace, and he's also treatment planning his first couple of osteotomy holes, which we'll call preps, but where he'll place the screws to stay away from the nerve in this case. And then he'll go back in now after he's finished. We've got a nice nice fracture possibility that's been stabilized. The patient healed normally with no consequences. So you're starting to notice that in dynamic navigation, as in anything in digital dentistry or anything in digital arena as a whole, your cars or TVs or any kind of audio video, everything's always advancing. And they are having more off-label utilizations that will then be, after studies, will even be brought into mainstream and be approved. So now using this type of technology, we can do molar endo access when you would have a really tight or constricted canal. And that's now been FDA approved. So in my patient, you wonder, again, when we're talking why navigate, navigation is going to provide us the accuracy of guides, but it solves some challenges with guides. It's not as costly. We don't have to worry about the room that's available in the patient's mouth with the guide in place. And it gives us accuracy in microns with surgical flexibility over freehand. And I'll pull Dr. Robert Emery, R.W. Emery's quote, but in my practice since 2016, it's pretty much every patient, every implant, every time. There's not a case that's too simple to just not utilize this concept and turn around in freehand. And you'll notice that Dr. Block and all back in 2017 when they were looking at freehand versus partially guided or fully guided cases. And these are guided cases with static guides as well. But you'll see in each of these cases, the guided surgery has a less angle of deviation from the platform or the apical depth than what a person would typically do freehand. And on the right, you'll see one of the screenshots taken during my surgery. And you can see here at a depth of 10.6 millimeters, it's only like half a degree off. So this also shows that we get to follow our bullseye. In this particular software, 9 o'clock is always going to be the finishing spot. So it's going to be yellow all the way to about a half millimeter from your final depth, then it'll turn green. And then you'll hear an audible click. You can also follow it in the 3 screens in the monitor as well, showing you just make sure you're right in your treatment planned implant. And then again, why navigate? Because we'll look at our post accuracy analysis. So here's a case where after you do your case, you can, if you take a post-op CBCT in your first few cases or in any case, and you want to see how accurate you were as far as placing the implant exactly where you planned. Well, you can see here that we planned this one to be the dark blue outline, and you see I'm pretty much dead on there with the lighter blue. And that's normal to have just a little bit of variation, because in this case, you're probably when the implant's placed, this cortical lingual bone's going to kick it off a little bit. And then you notice every time you look at your slow speed handpiece, there's going to be a little wobble with the attachment to that when you click your osteotomy burr or your slow round when you're doing restorative. So that would give you that type of deviation. But going back to the Block study, it's about 11% more accurate in these studies when you're utilizing guidance versus freehand. So when we're looking at dynamically guided or freehand, what's driving us to this? And here's an article by Dr. Emery and Merritt. But when you're noticing, you know, when your patients come in now, you need to have your plan and your final prosthetics to be aesthetic and hygienic. And you know, they are reading now. You've got a very educated clientele who come to your office and have done their research on implants and guides and implant companies. So you've got to have the ability to be able to converse with them. and kind of give them your rationale. So ideal positioning is going to help you. Prosthetically driven implant placement. It's going to tell you, am I able to use this site right now for an implant, or am I going to need to do some pre-grafting? And then finally, it's going to improve our accuracy. And for me, that really gives me the confidence to know, hey, that's why I'm going to do this every implant, every patient, every time. Here's some benefits of dynamic navigation. We've got a parallel tool that helps us with our virtual implant placement. Here's a man who was about a month from retiring, working on his at the job, and had a high pressure hose come loose and pretty much break off both of his front teeth. So in this case, you see the incisive canal. So we got a big area there we want to avoid. You'll learn that we've got markers around these. This is in DTX. You'll see that there's a 1.5 millimeter halo. So that lets you know that, hey, we're at least 1.5 millimeters away from the laterals, a good 1.5 millimeters away from the incisive canal. And is there any way that I can parallel these? Because I'd like to place him in a temporary if possible. You'll see here in the case with the patient, we have not had any incision. We were able to atraumatically extract the teeth and keep nice four-wall defect with no worries about the buccal wall. So we've had no disruption of blood flow from the periosteum if we don't have to lay a flap. And the other thing is we can always utilize this type of dynamic surgery for real-time modifications. In this case, we were able to send his CBCT an intraoral scan of his teeth before we took them out to the lab. They were able to make me like a temporary shell. You'll see here that we've designed these in such a way that obviously the temporaries are going to have a little screw access that you can kind of see, but there will be nothing that won't be easily fixed with an angled screw channel when we do the final. We've got little wings here that are present to help us in positioning and holding our temporary in place and helping us capture our temporary coping. And then when we look here, we've got nice stippled free gingival tissue. This is like 5 days after, so it doesn't even look like he's had any issue with this. We've got him shorter, obviously, than the other teeth to keep him from having any extrusive contacts. But he's very happy. This is helping us also stabilize our hard and soft tissue immediately after the extraction, and it also helps us stabilize our graft material. When we're talking about navigation options, you can use an X-clip and your CBCT to register your patient. Now, again, we talk about the advancements in the 5 or 6 years that I've had my technology. We now have seen where they're able to send us another type of technology called X-Mark, where we don't need an X-clip in their CBCT. We're able just to take a CBCT that we take, or take a CBCT that your referring docs may send you, and treatment plan that as well at that time. We are utilizing this for a completely edentulous and terminal dentition. It helps us with our ridge reduction planning and actual treatment. We'll be able to use completely edentulous or terminal dentition. Dual scan techniques and EDX screws now are an advancement that's easier for us to attach a patient locator arm. And then finally, we'll use completely edentulous, maybe opposing fixed teeth and implants, where we use all three. A cool thing to notice here, I won't spend too much time on it, but those are things that we'll need to take, like a water bath or X-clip, intraoral scan, CBCT. As you look down through all those, the ones in the blue can be easily done by your assistant. So you give them guidance, they really get involved in this. They're really, instead of looking at it as a new piece of material or a new piece of equipment or a new hurdle they got to jump through, if you can get them involved at the beginning, they're on board. This is fun for them. They enjoy being involved in the treatment planning, and there's a lot that they can do getting you ready for surgery and for the surgery day. Finally, you'll see the live navigation, the system checks, and the full guide placement would be something that would be finalized by the dentist. So let's talk a little bit about my decision tree. So when we're thinking about an extraction, in our planning, we're trying to think, okay, is this going to be an immediate implant placement, and the advantages that give us, or is it something that we need to extract and graft or regenerate some bone? What kind of provisional are we going to use? An Essex appliance, or are we going to be able to do a temporary screw retained crown like you saw before, or a temporary socket seal provisional, which would be maybe it's a temporary crown, but not having the actual crown stopping right above the gum line. It's still going to do the benefits of holding everything, the hard and soft tissue in place, keeping our bone graft in place. But if someone had a really deep bite, maybe they're better off not having occlusion on that at that time. But you've still got your temporary that's working to kind of keep your emergence profile just the same as it was before the tooth was extracted. And then finally, your dynamic treatment planning and surgery. As you heard me mention, immediate provisionalization, try to do this as much as we can. There's a nice textbook by Georgios Romanos, and he's shown where bone density will increase at the bone implant interface with early loading. The bone implant contact can be enhanced, and our woven bone can mature into coarser laminar bone. And then I'm sure you all have heard of Ostel or ISQ. It's a great tool to have also, so you can kind of check your bone implant contact at your time of your placement, just to make sure it looks like it's one that you can load. Another rationale for this is you'll see that it reduces your treatment time. The bone's stronger with progressively loaded implants. You're going to have less remodeling of your hard and soft tissues. You're going to have ability of your provisional, as we mentioned, to contain the bone grafting material. And obviously the patient's acceptance of your provisional is going to be stepped up quite nicely. Now, you have to pick and choose your patients. It's always nice. I'm a general dentist, so I am going to do the surgery and I'm going to do the restoration. So a lot of these patients have been in my office for a long time. Then I feel more comfortable that they will or will not follow instructions I give them. So this would be one that you would, make sure you had someone that would follow your soft eating food and wear their night guard instructions. Again, here's just a shot of tooth number 8. You'll see I've got it a little shorter than number 9, but it's healing nicely. Again, we've maintained our soft tissue, and it's helping us keep our graft in place, and we're idealizing the soft tissue concepts and contours early to help us during the final prosthetic phase. And this is a great article by Dr. Stumpo and Wadwani mentioning custom healing abutments for these immediate or delayed immediate cases. Here's an article that just came out by Dr. Alessandro Pozzi et al. And he is showing a new novel digital workflow. And you can see here he has in the top tooth, these are his photos where the tooth was extracted or they're planning the extraction. They have designed a temporary with the flanges to show a photo of the intraoperative surgery. And then there's a post-operative result. And in his clinic, he's kind of broken this down as far as time that's involved. So taking a CBCT, 10 minutes, intraoral scanning, 5.5 minutes, virtual patient digital assisting treatment planning, 6 minutes, exporting the file to a lab or dedicated software at your office and mill this temporary shell, 40 minutes. Export the file then from the temporary shell to the navigation surgery system, and then calibrating and doing the guided surgery, 25 minutes. And finally, adaptation of your temporary for 20 minutes. So in his office, it's fairly productive, 82 minutes. In my office, I don't really worry that much about speed. Again, I'm a general dentist, so implants are growing and becoming more of an option and more of a productive part of my machine. But I'm never really worried that much about how fast I can do it. I look at digital aspect as far as when I do these procedures, I want to treatment plan them. I want to give a patient a prosthesis, and we're going to be like a UK basketball player. A lot of times they're one and done. You know, I want to have a one and done type of concept with the implant, to where we've done all we can do to design it and get it made to optimal health for the implant table to be. So then when we finally restore it, again with prosthetic concerns that need to be addressed, that we know that once we place that one, we've done the best we can do. And as long as the patient's body takes over and heals correctly, we're in great shape. So I'm going to walk you through a simple case here. This is an implant surgery in site number 19. A patient of mine was skiing in Telluride one Christmas, calls he has a bad toothache. The tooth is split. The dentist there did a wonderful job. He took out number 19 and he preserved the socket. Now, here's a cool thing, intraoral scans. For this patient, we'd done an intraoral scan for a clear correct aligner. So remember the days when you had all your casts and you would do a cast on a patient for aligners, for crowns, and when you were through with the case, you know, usually they went in the trash. Well, the cool thing about data, digital data, you've got these in files at your hand that you're able to pull up. So we're able to treatment plan him, and you'll see as we go through this, his intraoral scan is helping us treatment plan it with a tooth that's no longer there, but a tooth number 19 had been in his mouth for 70 years, so we're able to build it back to the same type of contours. So we took a CBCT in March after 3 months of healing. In this case, it's just the preliminary treatment planning on the CBC software. We placed a Nobel 5 by 11.5 Nobel Active in this site. And then what we've done now is, as you mentioned earlier, we've taken the CBCT and the intraoral scan, and we're able to push this and merge it over into DTX Studio implant treatment plan. And so we've got our implant placed. You can see again, here's our intraoral scan that shows us where the crown of the tooth is, both in this view as well as the occlusal view too on the model. We've got an implant placed, and in DTX has multiple implants. It'll have Nobel, the whole Nobel line. It'll have Implant Direct, Straumann. There's implants that you can choose from that you're utilizing. And in this case, I love this on-one abutment, especially for posterior teeth. So in this place, we're able to plan an on-one abutment, and we can look at it and see our soft tissue. So our studies are showing us again now, if we can stay a little taller on our abutment, at least 2.5 millimeters away from our implant abutment interface, it's going to help us with our, help us reduce any marginal bone loss, and also help us reduce peri-implantitis. That's been a common topic this spring that I saw from both podiums of the ICOI winter meeting here in Atlanta, at the AO meeting out in San Diego, and now recently at the Invista Summit in Austin. So you're going to, it's pretty interesting. It's kind of cool that we're seeing this mentioned on podiums as far as decreasing your chances of peri-implantitis and any kind of marginal bone loss. And we've been utilizing these abutments in armamentarium before. And then also, it's a cool thing now that I'm seeing some marginal muco-integration really good with this Zeal surface on the abutment. So now, after we've planned our implant crown and we're taking it to the surgery, we can look and see that in the X-Guide, in this case, it still has been directly imported from the DTX because it still has the shape of a Nobel implant. And you can see where we're going straight up through the crown that was there before on our intraoral scan. The squares around each are 1.5 millimeters and 3 millimeters, so we can tell how far we are from each tooth. And we can also look at the model and see if we like the emergence profile of our implant, and also to look and see, hey, is it in the center of the fossa if possible? And let's get this thing and make it designed to have a screw implant, a screw retained implant crown to even help us even better with no peri-implantitis to alleviate the chance of having cement. X-Guide now with X-Mark, you just pick 3 spots on the patient's mouth, and you pick 3 spots in the 3D rendering, just like you do a lot of times anytime you're doing a intraoral scan and merging files. And after those 3 picks, you'll see that we're able to confirm that, hey, we've got the patient, our locators in place. We're less than half a millimeter off from any of the 3 spots. And then when we'll do a final verification, we'll see that the actual probe that we're placing on the tooth is exactly where it needs to be on the incisal edge, on the buccal and the lingual. If it were not, we're able to step back 1 step further and do refinement and catch about 200 points on each tooth and tweak that in. When we see this surgery, we're looking again at the bullseye, and since this is a 5x11, like I said, 9 o'clock is always when you finish, so this is 11. If it were a 15 millimeter implant, it would still finish at 11. So you know when you're the operator and you're looking right at the monitor, that when we get to the 9 o'clock spot, we're going to be where we anticipated our final depth. And again, at the end, we were only a half a millimeter off, or I mean, half a degree off of our plan. This just shows our implant. We placed it, getting a little PRF. This is the on-one with the Zeal surface. And then that is attached. Again, you see we've got a very, very minimal disturbance of soft tissue. We've not really had to lay a flap at all. We just pretty much took a 12-inch scalpel blade and used a sharp molt just to spread that apart just enough to find the cortical plate and start our osteotomy. Here's the on-one abutment placed after we placed the implant. Again, hardly any tissue disruption. We've done a flapless surgical site, and we've got nice osteo readings in the 68 buccal lingual, 65 mesial distal. So we feel very comfortable going ahead and placing our temporary. Here's the temporary video that the lab, Jay had sent me from Root Dental, but he's developed a temporary pre-surgery, so he was able to see my implant, the emergence profile of the implant. He's able to design the crown, also with some help from Bill's original crown on his iOS. He's designed the access hole for where the coping will exit the implant, and he also has lingual wings to assist with seating. So here you'll see the on-one abutment, and obviously it needs to be shortened. So we've tightened it into place. There's our temporary shell again. We've now shortened the implant. We've tried in our crown to make sure there's no clearance. In this case, I think I had to make 1 little pass on the distal just to give enough room for the Logitech to come around and capture the temporary. Put a little silicone tape in the temporary hole, just so you don't mess up your screw hole, and then just seat it and capture it. So here you see us injecting the pickup resin. We're going to unscrew it and retrieve it, and very, very minimal polishing here. Again, this one was right on the maybe a millimeter subgingival. So and we're still, again, like I said earlier, that on-one is a wonderful abutment, or any kind of one-time abutment I think is great, because we're never going to disturb that implant abutment interface again. All of our work's going to be happening about, in this case, 2.5 millimeters above that. And if you read literature, you'll see that usually you'll see mentioned, like on a typical case, you may have 5 different times that you would have this implant abutment interface bothered by taking off your healing head, by taking off the provisional, by taking off healing abutment. So if we can stay above that, studies are showing us that it's going to be easier and better for the tissue. Here's our final delivery of the screw retained abutment. We've just covered up the hole again with silicone tape, a little flowable composite, and we just want to make sure we get it out of occlusion. Our post-op limited field CBCT is going to show us that here's our implant in red. Here's our 2.5 millimeter abutment, and then all our temporary and everything else from now on is going to be taking place on top of that. So we're not going to come back and disturb that again. So one of the other cool things we'll see, this is a nice article by Dr. Canullo and all, but etiological odds on contributing to peri-implantitis. And he had a nice article that showed, malpositioned implants were 48.2%, overloading 18.7%, prosthetic problem 3.72%, and smokers 1.79%. So right there should tell you, you've got the ability to guide your surgery, and you can treatment plan it, use the technology, guide every implant every time. And that's one of the reasons you're going to be able to hopefully do away with some or any of malpositioned implant errors. Here's the patient 5 days post-op with his temporary. Again, you see it's kind of shortened, but we didn't want him to function with it. We just want it to be clear. But we're already seeing early, healthy looking mucointertoration, and he's very pleased with the results. 5 days post-op, again, just a coronal view. Everything looks really nice. So we started with our edentulous site. There's the delivery of the temporary. There's a nice final PA of the permanent crown, and then there's our permanent crown in place. So when we're looking for areas and techniques to decrease any peri-implant tissue disturbances, we look back and we saw that there was minimal surgery, flapless or minimal was very much in demand. Minimal abutment changes, a one-time abutment, and then screw retained prosthetics over cement retained prosthetics will help us decrease the peri-implant tissue disturbances. So dynamic treatment planning with the surgery as far as, and dynamic treatment planning with surgical software can help us through some of those problems. And then real quickly before we finish up, I'll run you through a full arch case. Full arch case in my office, after the patient is pretty much satisfied with the treatment plan and accepted cost, then what we really need is one good 2-hour appointment to get a nice aesthetic evaluation. We'll get intraoral and extraoral photos, a CBCT scan. If edentulous, we'll do a dual scan of a newly made nice denture, ideal denture with the ideal occlusal schemes, or we use an intraoral scan. We can also take impressions or jaw relations the analog way. And then obviously, finally, you got to get a tooth mold and a shade selection. Here's a case where you see the patient has a full upper denture. He has a terminal lower dentition with a couple failing premolars, and then he had a couple of implants that were replaced, but I just could not utilize those in the full arch. So in this diagnostic workup, we really got to look at our aesthetic evaluation, our occlusal relationships. When we want to have anything full arch, we want to have a balanced occlusal scheme with minimal to no overlap or overjet, flat plane occlusion. You really want to pay attention to your lip line and your smile line. This is a transition line, so you want that patient to snarl as wide as they can. You want to make sure that all your planning is such that when you're finished, that his transition line is going to be up hidden under his lip. Here's a picture of intraoral scan that we'll utilize. His denture had a nice enough occlusal scheme that we could utilize that, but we wanted to make sure we also made him a new denture in this final prosthesis. So we lined that original denture with Improgum. While it was in the mouth, I took the excess of the Improgum away from the buccals and lingual so we could nail his bite registration. And then we take it, then we capture the lower arch, come back and then take the upper denture out and roll over the edges and capture his intaglio surface of the emperor gum. On the lower arch, or the arch that you're wanting to work with, especially you want to get nice full border extensions. And we're able to do that and send that to the lab. And the next step with Stephen Balshi is, you'll see here's the intraoral scan in blue, showing his flaring of his maxillary denture over his lower incisors. And then you'll see the denture setup, the teeth setup with the patient's mold that he selected. Again, we've got minimal overlap, nice flat plane occlusion. But if you look at it from side views, we've moved the teeth back. He doesn't have as much a class 2 with his anterior relationship. And you can also see that here. Here's where his initial natural teeth, and we moved his upper teeth back slightly. Once I approve that, then Stephen will take another few days in the lab, export my CBCT with my preliminary planned implants in place. And once that was finalized as far as the setup, then we will get together again and look at my preliminary implant setups and tweak those any way that need to be tweaked to have ideal placement. So coming out the occlusals of the posterior teeth and a little lingual here in the anterior. In this case, you can see we were lucky enough that we're able to do an all-on-6 and sneak 2 implants behind his mental foramen. EDX screws are what we utilize now to attach the patient tracker to an edentulous or a terminally edentulous arch where the teeth are not mobile enough to use an X-clip. So we can place, I have placed EDX screws by navigating those, but you'll just have to have a tooth that's sound enough for you to place your X-clip to guide you. Otherwise, we just use this to kind of eyeball where we need to have our EDX screws. And in this case, as I remember now, we did use I just snapped a quick X-clip on. I was do the X mark to register him with that, so I could just drill my 2 holes to start with for the EDX screws, mainly because this was close to a nerve and we had 2 implants up here to deal with. So we wanted those to be ideal, so I was able to guide those ETX initial holes. And then this gives you a chance that you'll see your EDX screw, you'll place 1 screw, and then the other one you have 10 to 15. That's a 5mm slot to place the other to screw. These guys are really robust, nice screws that will fixate the patient's jaw, and you can take your hand and just wiggle his jaw with the patient tracker. Moving forward in planning, this is definitely guided. After we've done that, you may have seen this other small little prep implants placed. These are called preps. They're a little bit smaller, but in this case, we have located our 1.5 millimeters or so above the implant, and this is where we're going to do our bone reduction. So we're able to touch each of these 25A, and that's where our bone reduction is going to be. And here's how it looks. We go back and we would just guide each one of those at 25A. We would drill a hole with our osteotomy drill, guided just where it was, and just move right on across the arch. And once we've done that, we just connect the dots, in this case with rongeurs or a surgical burr or piezo, and then come back with our final burr recontouring and reconstruction. This was a maxillary complete denture and a mandibular convertible provisional. So this patient, you saw him, we saw him for his digital appointment, and really we just needed to see him one more time, like a couple of days before the surgery for a pre-op, give him his pre-op medications. We needed nothing else that would needed to be done from a clinical standpoint. And so here's a nice paper by Stephen Balshi and Tom Balshi and all, but this shows that what they've designed here is with this provisional, we have the provisional that's made with the patient's preordained vertical dimension. So we've got our maxillary CD. Or in this case, that's fixed, or it could be a maxillary tooth-borne dentition with the lower provisional. The provisional is going to have a occlusal lock with an upper tooth that keeps it in place. So you can take your handle and turn this upside down. The maxillary denture would not fall off. It'll have a positioning handle in the middle that'll help you kind of guide the patient up when he's closed, when you're doing your capture. And then we have access holes for the temporary abutments to come from, as well as slots that we're able to, if the patient, that we're able to use that to go ahead and do our initial removal of the flanges. This is one cool case, and you do not have to make two appliances. So like, especially if you were doing like a maxillary arch and you just did not get the torque values or the ISQ readings that you needed to feel comfortable loading these, then you just go right back, put a little cold cure acrylic in these sites, and you're able to sleep your implants, but you've got the patient a denture to wear while they're sleeping and also integrating. Here's our provisional pickup conversion. Here again, we're talking about removing the handle and the flanges. I am taking this out of the patient's mouth. We've got it little squares of rubber dam to keep any kind of pickup from going into an undercut. And this is another great photo. Here's my assistant. She has watched many videos, and she's also watched lab techs when they come to the office to take part in this conversion, and she loves doing this. So I will take off the appliance, give it to her. She will go in after we picked it up, remove the flanges, fill in the void, make it nice and cleansable for the patient. And I will be doing any bone grafting and suturing to close. This was the temporary, the intaglio surface, as well as the occlusal surface. Here's the temporary with the denture in place. And 6 months later, we come back. Here's a case where we've taken a scan of the patient's provisional. We'll be able to send that to the lab. JC and the guys at Root are able to utilize this to help us determine our existing vertical midlines and aesthetics, and also they can look at anything that the patient may not want. You know, I can make that on the note, and we're also going to be able to duplicate his bite registration. So the first time I'm going to see the patient after this is he's going to come in and have teeth in the anterior where we've got it in wax, and we've got our well, you can see here the posterior is pretty much dead on. The bite looks really great with their bite seating jig. So it's very productive, great use of chair time, and it's these kind of transfer a lot of information. And here we are finally with our maxillary CD over top of our mandibular screw retained appliance. Here's our 6 implants. We've got the multi-units, and again, they've got the Zeal surfacing. So really nice connected keratinized tissue. Loving the way this one's healing, and the patient's very, very happy with the final results. Here's one final article with Dr. Craig Mish will show nowadays you're hearing a graftless approach. You know, where we're showing studies that most of the stresses on an implant are in the crestal region. So why not have a shorter implant these days and maybe not have to have a patient go through so much grafting? Or in this case, we're able to use these shorter implants in the rear, which were 8.5 millimeters in depth, but they're giving us a great distal extension, and we're not having to worry about an all-on-4. So he's going to get a nice result, especially with his maxillary denture. And should the time ever come that he would want to convert to the maxillary all-on-4, all-on-6, we're able to do that. So I know kind of run through a lot in a short amount of time, but kind of wanted to give you a little bit of information on both the single and the full arch. Here's a course that I'm happy to be invited to participate in with Dr. John Russo. It's in Siesta Key, Sarasota. It does it about 3 times this year. On a Friday, for instance, Dr. Russo will have a patient that he will place a single or a double implant singles. In the afternoon, it's hands-on. Again, it's great for the dentist and also for staff, because I hope I've shown you, but the staffs are really, really involved in this a lot from the treatment standpoint, and also when we're dealing with our patients. And in the afternoon, we'll have laptops and we'll have hands-on, and you'll get to see how to place EDX screws and how to plan these in the software. And in the second day, Dr. R.W. Emery is down from his practice in Washington, D.C., and he will do a full arch case, and all on 4 or all on 6. And we'll go through in the morning that surgery. He'll do the surgery. A prosthodontist will be there to do the final pickup. And then in the afternoons, again, there's more computer time and treatment planning on how I went through that really quickly, but how we plan our EDX screws and how we plan the bone graft. I really thank you all for tuning in. You got to get that y'all in there. If you haven't figured it out yet, I've been in Atlanta for 34 years, so I got a little bit of that Southern draw, but originally I'm from Eastern Kentucky. So the Hatfield in me comes out as well. I thank so much Viva Learning for hosting me, and there's my contact information. You're more welcome to email me or call me if you have any questions. There's been a few questions that have come through the Q&A, so let me look here. Are newer devices and handpieces less bulky? I haven't seen anything less bulky. Those are really kind of light anyway. So if you get a chance to be at a meeting or stop by one of their tables, you will see that it's really no issue. I will tell you, at least it's a good 10 cases before you're, really adept at the learning curve. They do a wonderful job of coming in, training you. And then they'll be there for you for training for you and your staff, and also for a morning of a couple surgeries. And from when you're talking, which everybody does, when you're wanting to talk about full arch, you've got to have documentation of at least 10 single cases before you can get the full arch kit or the full arch software turned on. How long do you wait before placing the final implant? I used to wait typically 3 to 4 months on the mandibular arch, 5 to 6 months on the maxillary arch. Now with the ISQ readings, we've got Ostel, where we'll take readings on either, in my place, like you guys saw, I did a few on ones. We can test on that platform, or we can test right into the implant. But as soon as I get a 70 reading on the ISQ, I'm ready to go. So for instance, the last week I had a person that was in that I think two individuals, we did 2 premolars. One was immediate, and in 3 months, it was ready to impress. And she had like 40s and 45 when we started, and 70 when we did the impression. Next lady was still probably the same amount of time difference, and she was in a healed site, so she had a higher reading of like a 60, and then it was like a 58 when I was testing it at 2 months. So in that case, I just put the healing abutment back on, or the healing socket seal, and told her to come back in her couple months, and we'll test again. A question was, what is the goal of a transition line in a full arch? A transition line is when you smile. The transition line is in the full arch. If you're going to leave it cemented and you don't need lip support for a patient, or even if you do need lip support, you have to plan that in your screw retained. But if you need lip support, you can do like a bar overdenture. So there you're not worried about the transition line, because you're using your denture to help hold. When we're doing these kind of cases for full arch, where we're doing screw retention, you have to have a little space that the patient can clean above these. And they have to be flat, so they cannot come up over the buccal alveolar ridge. So in this case, you've got to make sure that as high as they can smile, that you've got enough bone reduction that you can place that transition line above their smile line. What's the CBCT you use in your office, and would you buy it again? You know, this is, I think I've done a good job of trying to give you an idea of not a corporate lecture, but a generic lecture. But I think this question is fine for me to answer. I have used Carestream Dental 8100 for probably 12 years, and I am going to be replacing that with the Carestream 9600 in sometime this summer. I really had no issues with that, so I would buy it again. It has great software, and I had great reliability with that. Do all companies have surgical kits for implant guided procedures? I would say most do. The cool thing about the dynamic guided, though, we're not using any surgical kit. So we're just using our, well, it is a surgical kit, but not a surgical guide kit. So you just use your regular osteotomy burrs, or if you want to use a Versa burr, you're not limited. You don't have keys or slots or any kind of holes like that. You don't have to buy any extra armamentarium. Do you use EDX screws every time, or does it depends on the case? It depends on the case. We'll use them the majority of the time when we're doing a full arch. On single implants, you just use the X clip, and the X clip you saw as I ran through the single case. But look, you can look up, call your local Dexis rep. They can give you some feedback, or look at X Guide on the website, and you'll see what the X clip and the EDX screws look like. What's the shortest implant posterior to the middle frame that I would use for an all-on-6? I like to have those 8 millimeters, 7-8 millimeters if I can. I don't know that I've done any shorter than that. I have used some in the past. I did use a shorter, like a 5x5 Bicon, but I just don't like those for my all-on 6s. But I think, you know, if you've got good solid bone and you can get a nice 7 millimeter implant behind there, it's going to be a world of difference. And in guided, you're able to kind of, even if your alveolar nerve may be a little bit shallow, if you've got enough width that you can move it buccal or lingual to it, you can guide that in a way that you can kind of feel comfortable. And anything you get behind there, I think is just going to be wonderful for your long-term success. Kind of bone graft size mixture is best for socket enhancement, socket preservation. I like at that 100 micron mixture. It usually we'll do a 50-50 mix if we're using PRF. Sometimes if we don't use PRF, we'll use a little more demineralized. For this, I would point you in the direction of Salvin Dental is who I utilize a lot for the biologics. Cool. That looks like most of the questions. Hope you guys were really all the questions, and I had a couple of nice comments. So I really appreciate those as well. You know, I hope you can see from my lecture that I'm really excited about digital technology. And I tell you, I would not have looked back on one day of purchasing my dynamic navigation for my placements. And then now, since then, it's been amazing how much I'm learning on just a treatment planning and setting some of these cases up. I learn from doing that every day in my office, and thanks to you guys a lot. I learn a lot, when I'm trying to put together one of these 45-minute sessions. So appreciate your attendance, and I will turn this back over to the moderator with Viva Learning. Please feel free to reach out to me if you have any other questions or any questions about the Russo course. Thank you so much.